Good afternoon, everyone. Thank you so much for being here. My name is Caitlin Saladino. I'm the Senior Director of Research and Development here at Brookings Mountain West. And on behalf of my colleagues, Bill Brown, Ashley LeClaire, our entire team of student workers, our Executive Director, Dave Demore, I want to thank you all for being here for this really important topic on the fentanyl crisis here in our community, and of course, the UNLV community response to it. I always want to take a moment to acknowledge our donors to Brookings Mountain West. We would not be able to put on the events that we do, especially ones like this, without their support, so we're incredibly grateful. And we also want to thank our colleagues at UNLV TV who are helping in the back of the room to record this event. For any of you that may have colleagues who are unable to be here today, but you want to share this really important conversation with them after the fact, this will be available on our website in a few short days. I also want to take a moment to thank our panelists and everyone who will be participating in the event today. I'm going to read their names and titles, and as I do, I'll invite them to come and join us up here. We are joined today by Vanda Felbab-Brown, who's a Brookings Institution Senior Fellow in Foreign Policy at the Strobe Talbot Center for Security, Strategy, and Technology. We're joined by our three colleagues from the UNLV School of Medicine, Lisa Durrett, who's an Associate Professor, Child and Adolescent Psychiatry Fellowship Program Director, Chair of the Department of Psychiatry and Behavioral Health, Sarah Hunt, who is the Executive Director of Be Here Nevada, an Associate Professor in the Department of Psychiatry and Behavioral Health and Director of the UNLV Mental and Behavioral Health Training Coalition, Annie Weisman, who is an Associate Professor and Director of Wellbeing and Integrative Medicine, and of course, our UNLV faculty colleague from the Greenspan College of Urban Affairs, Alexis Kennedy, who's a professor in criminal justice. Before I turn things over to Vanda, I want to give you all a little bit of background about how we ended up on this stage today, so bear with me. For those of you who don't know us, Brookings Mountain West is a relationship between UNLV and the prestigious Brookings Institution in Washington, D.C. As part of this unique partnership, Brookings Mountain West has the privilege of bringing out our colleagues from DC and Brookings for week-long residencies here at UNLV throughout the academic year. They teach courses in the Brookings Public Policy minor. They also meet with policymakers, share their insight, and offer experiences and insights about how to improve the Las Vegas community through public policy. Our Brookings colleague, Vanda Felbab-Brown, has been part of this partnership with us for the past 15 years. She's shared her expertise with the UNLV community on everything from wildlife trafficking, organized crime and international conflicts, to illicit economies, the opioid epidemic, and specifically the fentanyl crisis, both here in our community and, of course, internationally. Her work on that last topic has been the highlight of much of her recent publication and scholarship, and about 18 months ago, we were very grateful to be able to connect Vanda with some of our incredible UNLV faculty who are working on the front lines of this crisis. And their perspectives as researchers and practitioners were invaluable both to her work and likewise to theirs. Fortunately for all of us, the conversation went really well. So well that as Vanda was preparing to produce a national level podcast through the Brookings Institution titled The Killing Drugs, Synthetic Opioids Around the World, which was released about 6 months ago, they were able to include the voices of these esteemed colleagues here. So if you've not had a chance to listen to the podcast, I encourage you to do so, not just because the amazing voices of Lisa, Sarah, Annie, and Alexis are in it, but because the final 2 episodes of the first season of this series feature their voices, their unique on-the-ground perspectives, and the things that they are seeing here in our community. And today, of course, we'll get the chance to expand on that conversation from the podcast and update what's been happening related to the fentanyl crisis in our community since the release of the podcast. After the panel discussion today, we'll have a few minutes for Q&A. We'll come around with a microphone, so bear with us so we can capture that for our recording. And with that, I'll ask you all to help me give a warm welcome to our panelists and to Vanda as she takes it away.
Well, thank you very much, Caitlin, for the very warm welcome. Enormous thanks to Bill, David, Ashley, the UNLV community for the partnership that we have with Brookings Mountain West, with the university. It's always an enormous pleasure for me to come to Las Vegas, to the university. Caitlin, you have been very kind in mentioning some of the knowledge that we try to bring in perspectives from federal level policy that we try to bring, but I always learn tremendous amount being here, whether it's from my terrific co-panelists today, as featured in various dimensions of the work, like the podcast, The Killing Drugs, or many others. For example, some of the work that I have done on water smuggling, water trafficking, water theft really emerged very much out of discussions and was enriched by discussions here at the university and with Brookings Mountain West. So it's always a delight to be here. And a lot of that collaboration really came wonderfully together in the project that I have been running at Brookings on opioids and fentanyl. So a lot of my work at Brookings and my management at Brookings has to deal with drug trafficking, and that for some 8 years has intensely focused on opioids. And over the past 2 years, that then congealed into a project called the fentanyl epidemic in North America and the global reach of synthetic opioids. A important culmination of the project was a series of events and products that we put out in December. You can find them on the landing page of the project, the fentanyl epidemic in North America and the global reach of opioids. You will find 14 in-depth papers on many dimensions of policy, from treatment, harm reduction, decriminalization, to domestic enforcement, international supply enforcement, specific communities such as Native American communities and how they have been impacted by fentanyl. So if it's of any interest and use, there's a wealth of knowledge in those papers. And as Caitlin already mentioned, another product that came out, in fact, earlier has been the podcast, The Killing Drugs. And the final 2 episodes of the podcast were recorded here at UNLV and were recorded with Sarah, Alexis, Annie, and Lisa. And I must say they were enormously popular episodes. So if you don't listen to any of the other episodes in the show, do listen to these 2. I constantly hear praise for them and engagement with them, even though they had come out in October. And hopefully we will have season 2 of the show, and I look forward to further opportunities for local voices and very important informed local voices. So we will today have a conversation with my esteemed co-panelist about what's been happening in Nevada, what has happened since the shows were recorded in October, and with all of you. And I know there are many community members bringing in a lot of knowledge as well. So I will be asking questions to my colleagues here. But before I do that, perhaps I'll start with you, Lisa, and just go down the road. If you can just give us a little bit of a framing of what discipline, what perspective, what angle do you come in to engage with opioid, substance use, fentanyl here in Nevada and Las Vegas?
Well, thank you for bringing this whole topic to light. And I think it's a super important topic for us to consider. So my core training is as a child and adolescent psychiatrist, as well as an addiction medicine doctor. And so to me, the concept of substance use, substance misuse, risk of substances starts as early as elementary school, which some people might think is a completely wild idea. Why would we even talk about it in kids this young? And when we think about, for example, what places somebody at a greater risk and or what protective factors can be instilled, there are interventions that can happen at the youngest age that can then transcend the entire lifespan, as some of my colleagues that work with more adults can discuss. So I am especially appreciative of having the topic come to light because of the patients that we see from those on our consult liaison service at UMC Hospital, where we'll see youth from all across Clark County and beyond, in our outpatient clinic operations, and then through some of our integrated care practices that we do with primary care. The impact of substance use is very widespread, and it starts at a young age.
Well, and in fact, the title of one of the episodes was From the Cradle to the Grave. And, Annie, with that, I'll turn to you. Please, if you just explain the context of how you engage with this topic.
Absolutely. So I engage with this topic more towards end of life. My background is hospice and HIV and AIDS. And so I'm a social behavioral public health scholar. And so I look at populations and pain and how we cope or how we self-medicate. And in the aftermath of the shooting that we had here in 2017, I was invited to start doing some work with our coroner's office. So I was teaching mind-body medicine, like coping skills, to those who had served and helped our community so much in that aftermath. And the coroner started talking to me about this particular problem. And for me personally, I have almost 21 years of recovery under my belt that I practice. So I'm really passionate about it because I think, what if I had learned younger ways to cope or different ways to manage life? So I'm really passionate about working on this.
Well, extremely important. And one of the aspects that we have tried to hone in the papers, in the podcast, and today in the conversation is the interaction of policy, but also the individual experience. Sarah, with that, what is the policy level that you're dealing with here?
So I kind of come at this topic from a workforce development piece. My work at UNLV focuses on mental and behavioral health workforce development. So it's probably no new news to anybody in this room that across our state, we are woefully short of all sorts of mental and behavioral health professionals, certainly including addictions counselors. And so what I try to look at it from a policy standpoint is what can we do to recruit more individuals to go into mental and behavioral health careers? How can we get them to stay here in Nevada and train them in our higher education system? And then how do we get them to stay in Nevada after they graduate? Do they find the process easy to get licensed and find employment, get paneled with insurance companies to be able to provide that necessary care?
Terrific. And Alexis, please.
I study victims and juvenile justice, as well as kids involved in child welfare, and these kids are often disenfranchised in pain, psychological pain, and turning to drugs to numb themselves to fit into new groups is a very logical thing. So I'm sort of looking at it in terms of how do we move towards the harm reduction that not everybody wants to talk about, but face the reality that there's drugs in every single school in Clark County, and it's very easy for kids to find their way to them.
And of course, there is a sort of badly reinforcing dynamic. They are traumatized, victimized to start with. They self-medicate with drugs and end up even more exposed to the criminal justice system. So these are the topics that we will be covering in the conversation. But before I start asking questions, perhaps let me give you a bit of a national level snapshot, both what's been happening in terms of drug trends and fentanyl overdoses, and what's been happening at the level of policy. So when fentanyl, a form of synthetic opioid, entered the US recreational drug market around 2012, it set off the deadliest epidemic in North America, and in fact, the deadliest epidemic in the world. One of the reasons that the podcast was called The Killing Drugs is because synthetic opioids are so very lethal. And so all of a sudden, we saw vast escalations of deaths that in its worst years would reach more than 100,000 people in the United States dying as a result of drug toxicity, as a result of lethal drug overdose, and cumulatively brought fentanyl to be the #1 cause of people between the age of 18 and 49. So there's no mean statistics to put out. So far, more people have died of drug overdose, fentanyl mostly, although we increasingly see also very lethal methamphetamine, than the number of Americans in all wars since World War II. That number is over 100 million, over 500,000 people. And finally, since about May 2023, we saw overdoses going down. A wide set of factors came together in why overdoses have declined, and there is a lot of competing views as to what accounted for the decline. My personal view is that the availability of naloxone, which is a medication that reverses overdose, was crucial, as was more of a mainstreaming of medication treatment for people with substance use disorder. So this would be medications like buprenorphine. And the mainstreaming was really developing since the Obama administration and had to do both with going away from stigma and taboo to expanding insurance coverage that would cover people using drugs. Even so, even at the end of the Biden administration, we had nationally perhaps only 20% of people using drugs and seeking actively treatment, being able to access treatment. And that even doesn't say anything about the quality of the treatment, which still varied. But nonetheless, all kinds of positive developments took place over that 12-year period, really spanning the Obama administration, which first encountered the crisis, the first Trump administration, and then the Biden administration, or 16-year period. So now the Trump administration comes into office, and we are seeing a variety of changes, some of which are already unfolding, others which are anticipated. One is, of course, that the Trump administration has put very strong emphasis on reducing the supply. That has traditionally been part of US drug policy, including in the Biden administration, but essentially putting the onus of stopping the supply of illicit drug on specific countries, which would be China, the source of precursor chemicals for fentanyl, Mexico, where the Mexican cartels produce fentanyl from the precursor chemicals, and somewhat oddly, Canada, where the United States has really not been receiving fentanyl in any significant way from Canada. Canada is dealing with all kinds of changes and challenges related to organized crime, such as extensive money laundering issues, growing presence of both Mexican cartels and Chinese criminal groups, but it's not been a significant source of fentanyl for the US. In fact, more fentanyl has been illicitly smuggled from the US to Canada than vice versa by an order of magnitude, yet Canada was subjected to the tariffs. So we saw tariffs being imposed on all three countries. We saw the Trump administration designating Mexican cartels as foreign terrorist organizations. That has profound implications for all manner of US-Mexico engagements and even other countries, because the material support clauses do not have any territorial limitations, and any kind of transaction that at the end leads to some money or some material support heading to the criminal group, such as through extortion, can be very heavily penalized and is criminalized in the United States with lengthy imprisonment and financial penalties. And then we see lots of changes at the domestic level. President Trump has repeatedly spoken about his desire to impose death penalty on drug dealers. Yet drug dealers are not just the kind of El Chapo traffickers. Many users are dealers themselves. Often the dealer is the classmate, the friend that provides the drug that supports addiction or that could result in the lethal overdose. So criminalizing of dealers, especially very strong criminalization, could affect vast numbers of people. Similarly, there are some propositions to even return to criminalizing use and possession of drugs for use with prison penalties. There is an executive order that explores, has not yet been officially established, that would designate fentanyl as a weapon of mass destruction that's widely popular with families of victims, yet could again lead to vast criminalization of all kinds of modalities, even perhaps drug testing, as even trace amounts could be criminalized under that designation. And of course, there are vast changes to insurance. changes to Medicaid, changes to other coverage that could further shrink the number of people who have access to treatment, especially medication-based treatment. So very significant changes at the federal level, along with, of course, reductions of budgets for CDCs, for NIH, reductions of budgets for SAMHSA, even some proposals to eliminate the part of the Health and Human Services Department that deals specifically with substance use, that will start significantly impacting not just the federal level, but states and community level. So a lot of changes being implemented and coming up. So with this context, let me turn to you, Sarah, first to ask, since we recorded the episodes, what has been happening in Nevada? Has Nevada been able to see a similar decline in drug overdose that we have seen at the national level? What's been happening with the trends on policy as well as in the market here?
Well, I'll start with just a few of the statistics about overdose and overdose deaths. So we have actually seen some increases. I was looking at data from just the past few months, but also the past couple of years. And we do see some increases in overdose encounters in emergency departments in certain populations. So there's been an insignificant increase in males, in patients identified as white or Black patients, and also the same trend in overdose deaths in those same populations. In, let's see, 2023, the overdose death count was 771 for Nevada. So while some of the other populations may be kind of plateauing, there's still some increases in overdose death due to opioids and just overdose presentations.
Well, let me ask about that. At the national level, I mentioned that we saw significant declines in the aggregate, but we also saw increases in overdose deaths for some populations. Native American communities, Black, especially Black men, saw increases, and rural communities overall did worse than urban communities, which essentially suggested that where there is access to treatment, the outcomes are much better. What, in your view, explains the increases here in some of the populations?
That I am not sure about. So I would have to look at the data a little bit closer, and I'm sure maybe some in the audience might have a better sense of that, especially those working in the field. In general, though, they also compare these increases in overdose deaths and presentation to the conflict with, well, it conflicts with, but the prescription rates of opioids have been going down significantly. So it's an interesting kind of look. There was a lot of policy that helped with the decreasing of prescribing opioids across the past couple of sessions in our state, but yet we're still seeing these contrasting increases.
Lisa, let me turn to you. So the over-prescription mismanagement starting in the 1990s, and of course, the role of actors like Purdue Pharma that were so complicit in shoving prescription opioids down everyone's throat, has been one very important source of substance use development. And that surpassed in many ways, added to the traditional initiation, which would often be at the young level, as young people start experimenting with drugs. Many administrations, every single administration for decades and decades has tried to chip or find a way to engage in prevention and to discourage young people from experimenting with drugs, in addition or as opposed to the larger problem of people encountering prescription opioids and thus developing substance use. The Biden administration had the one pill can kill policy. You have been dealing a lot with families, with young people. In your view, what are the primary risk factors that bring young people to use that will be dangerous? And what is your view of the One Pill Can Kill campaign or similar programs of that kind?
See, the question around risk factors for adolescents just speaks to those elements that make an adolescent unique. And think back to when you guys were in high school and you'd see the different groups of people hanging out at the free time during lunch, and people would create their identities, and you'd have the goth kids or the preppy kids. And adolescence is a time of figuring out one's identity, where youth are going to identify more with their peers than with adults. And that brings about some certain vulnerabilities, depending upon which peer group you're with. For those youth that Alexis and I often work with who have been victims of abuse, neglect, trafficking, are involved in the criminal justice system, their cohort of peers are perhaps going to be a more high-risk group of individuals with whom they're identifying. So there's the identification and developing one's identity part. Another core element of adolescence just has to do with brain formation and the role of impulsivity and decision-making. And we know that the prefrontal cortex, that part of our brain that really helps differentiate us from other types of primates and helps with executive function and decision-making capacity, is not fully intact and ready to go until the mid-20s. And so by default, you've got a brain of a person who is going to be more prone to impulsive decision-making and has oftentimes that greater sense of invincibility. Oh, I can jump off that high surface and nothing bad is going to happen to me. So all of those are common risk factors to an adolescent outside of the realm of substance use. But then there's two pieces that I would add to this dilemma with regards to the risk of fentanyl and opiate exposure and death, and that is the low perception of harm. So here's a classic example. You're working with a child, a youth, whose mom might have, and I'm just picking on moms, it could be a dad, it could be an uncle, somebody in the family has an anxiety disorder, and they have observed that parent maybe using Xanax or Ativan or a benzodiazepine to relieve that anxiety. And there might be a hidden message that that's normalized. And so then talking to friends, they might identify, oh, there's those pills you can take to help you feel less anxious. You've got some tests coming up. You got to break up with a boyfriend, girlfriend, whatever. We're anxious. And now I've normalized the conversation of connecting a pill solution with an emotional state. And we also know that the access, when we talk about one pill can kill and the lacing and or the bastardization of the things that are sold as pills has been heavy. And I can tell you anecdotally of patients that we see at our local emergency department who have been coming in with overdoses, very frequently will test positive for fentanyl. I've never used fentanyl, but you're testing positive. Because as you discussed, the traffickers are manufacturing themselves these pills, and they're nearly indistinguishable. And from, one yellow bar with a line down the middle, is that Xanax laced with fentanyl? And it is more frequently available through social media. Mm-hmm. And so whereas for those of us that might be in a certain age group, our peers were those people we'd physically hang out with, now kids have this extended social network through social media where if the danger level is reduced, if the conversation, the permissiveness is more prevalent and more accessible, and now I can direct message somebody, I might have more access. And so those are some unique factors that really tie into the higher risk that I believe our teens can face right now.
Well, thank you, Lisa, for saying that, because we have heard, as we were working on the Brookings project, as we continue to work on it, so much about fentanyl as the equalization drug, affecting not just some specific subgroup, although affecting some subgroup like Black communities, Native American communities disproportionately, nonetheless affecting wealthy white enclaves. And I would regularly hear from parents in very wealthy, very affluent communities near Washington and elsewhere about their teenagers having died of drug overdose, perhaps thinking they were taking Adderall or some other medication for the stress related to a test, kids who would be very high-performing scholars, high-performing athletes, not knowing that they were given a drug that has a mixture in this, and often, not getting the drug from, some corner by a drug dealer with an eye patch and kind of black cap, as one would caricature, but their classmate. So, your point about this is affecting the normal kids, a wrong term to start with, but one that people would attribute, I think, is very important. Now, Alexis, let me come to you, because we spoke about the widespread impact on communities. But we've also heard about particularly communities at risk, such as young people who come in with trauma, who do not have the support networks that would be desirable. How well do we do as a country, as society, in screening for risk and shielding those kids from being exposed to even more danger, such as through the illicit drug market?
Yeah, as adults, when we're feeling stressed or worried or we're watching the news, we like to change our state by having a drink or doing something. My drug of choice is sugar, so ice cream. That makes me feel better. But I know intellectually it's not good for me. So we're judging kids for doing that exact same thing we do, which is wanting to change our state. So the kids that are dealing with being bullied at school, feeling like outsiders, navigating teenagehood, which is difficult, for them to have someone say, take this, it's going to make you feel better, that's really logical. But when they do it and something goes wrong, we're very quick to say, well, now you've messed up your life, now you're a juvenile delinquent. So any kid who's involved in child welfare, if they get caught with using drugs to modulate their feelings, they're going to be harder to place. If it's kids that are in juvenile justice already because they got caught doing graffiti or something, they are now not just a kid that's acting out, they're also a kid with a drug addiction problem. So we're not screening them, because when they come in to child welfare, to juvenile justice, we're trying to figure out where to place them. We don't always ask them if they're using drugs, and they don't want to disclose because they're just going to get pulled deeper into the system and get in more trouble. So we have to get better at noticing and not normalizing, but being empathetic to understand why it's actually really logical for them to want to escape feeling bad by, doing things that the grown-ups or the other kids around them are doing.
And so Alex is saying that you, and also Lisa, please come in. Obviously, there is huge disincentive to disclose. Mm-hmm. What would be some of the warning signs that adults, friends, other members, and it doesn't have to be just related to teenagers, could be kind of broadly to anyone, could notice as signs that there is substance use disorder going on?
Well, the warning signs are the same for a lot of different issues. If they're withdrawing, changing their friend group, just a real change in their behavior or attitude. That could be dating violence. That could be drug use. That could be being bullied at school. That could be, being abused by someone in a position of trust. The warning signs are always the same. When a kid is off and they're acting differently and, you're having trouble connecting with them, instead of just ignoring it, we have to try and pull in resources and be realistic about what they might be going through.
So one sign is radical changes in behavior. Mm-hmm. But many people who use drugs, including kids, also become very good at hiding it. Lisa, what else would you be looking for if not changes in behavior?
I mean, changes in behavior is that canary in the coal mine, the more subtle thing. Changes in grades, maybe money's missing at home, or the kids that are starting to go to places that they typically wouldn't go. But I also want to come back full circle to this concept of substance use disorder. So when we think about just the diagnosis, substance use disorder, opiate use disorder is a very specific diagnosis. And when we're talking about the impact of fentanyl and fentanyl overdoses, it is very rare that that's applying, at least in the adolescent population, to kids that meet the diagnostic criteria for a substance use disorder. These are kids that have made a really poor decision based upon a handful of circumstances, completely unintentionally at times, that unfortunately they get their hands on fentanyl. And so while I think we do a great job talking about substance use disorders and risks for substance use disorders, this discussion is a bit different because this is just kids getting their hands on as little as 1 or 2 pills, and that's all it takes.
Right. Which of course makes it just so much more challenging, both from the parenting perspective and from the policy perspective. Annie, let me come to you. So one, of course, dimension is trying to save people's lives and stabilize them. But we have also really just been devastating the crisis of deaths. Rand's study revealed that at least 1 in 8 Americans has known closely someone who died from fentanyl overdose. Just tremendous amount of people in some form in the community have dealt with both the manifestations of substance use disorder as well as the trauma of deaths, including obviously families and friends. What are some of the implications? What are some of the advice for people how to cope with that?
I think being in community is really important when we're in grief. The shame and the guilt and the fear and the complex emotions that co-occur with this type of death and loss are so enormous. So I think being in community wherever possible, if they're able to name how their loved one died and gather the support of others, I think that's really critical. Another complex factor with this is sometimes, depending on where the person dies, the amount of time that it takes for the family to get their body back and to actually have the funeral can be complicated by the sheer number of deaths by this in the communities that they're in. So there are a lot of complex factors here, and it makes grieving, even, which is difficult naturally, even more difficult.
And you bring up, which we have heard, several times, the issue of stigma. I'm also just so struck how there is stigma exhibited by doctors, who rather that doctors still exhibit resentment or unwillingness to deal with patients with substance use disorder. I would also hear from mothers who lost their children, or siblings who, or brothers and sisters who lost their siblings, saying, well, the family must have been bad, you must have been a bad mother because your son died as a result of drug overdose. So this issue is still very much embedded in the society, and of course can be greatly amplified if policies that criminalize use, criminalize engagement with drugs return to a great extent. Sarah, let me go back to you. And so one issue is the community response, the family response, the best advice that a parent, a sibling, a friend can take. But all of this is embedded, just as I mentioned with the issue of stigma, in the policy context. And the workforce that is available to be presenting evidence about best practices, most effective solutions, whether they are psychosocial therapy or they are medication-based therapy. You have been leading these efforts here in Nevada to develop the workforce. Can you tell us a bit about that?
Sure. So that is definitely my day job. So in the 2023 Nevada legislative session, we were fortunate to get a bill passed, Assembly Bill 37, that asked the Nevada system of higher education to establish a designated behavioral health workforce development center. And that was based on a model that's been successful in the state of Nebraska for over a decade, where they use state legislative action and state funds to create this workforce center, and have done a lot of great work in that space. Illinois did the same thing a year or two before we did in 2023, and then after we did, Florida did the same type of action. So in these behavioral health workforce development centers, we're all kind of following the same blueprint, where I'm a psychologist by training, and if you're a behavioral health professional, just historically, we haven't shown up in like the K through 12 space to talk about our career options. What that looks like, all the different ways when a high schooler comes up and says, yes, I want to be a therapist. Well, did you know you could be a therapist as a social worker, as a psychologist, as a marriage and family therapist? And so getting into that kind of detail. And so we, with this bill, it established what we call Be Here Nevada, and that's our Behavioral Health Workforce Development Center, and that's administratively housed at UNLV, but we work with all of the NSHE institutions and across the state. So we're doing those exact same things. We're going out to K through 12 spaces, showing up at any high school career fair across the state to just start talking to kids about what it means to work in mental health. And then ideally for those students that are interested in these career pathways, we want to make sure they understand the different doors that they can step into if they stay in Nevada, whether it's they start at College of Southern Nevada or they start at Great Basin in Pahrump, or they start at UNR or UNLV. But just so they know what's available in the field and what doors to step into. And then we do some of that work on the retention side. So as these students are getting trained how to be mental health professionals and they're getting close to graduation, we want to help them understand what's available for them to stay in Nevada afterwards, whether that's the pathway to licensure, do they understand all of the different student loan repayment programs that we offer if they stay and work in Nevada. So that is some of the work that we've been just starting to do since October of 2023 when we officially opened.
And Alexis, do we have a similar policy workforce development for people, for young people in the juvenile justice system, or do we at least have best practices to apply to them if they are in the juvenile justice system and also dealing with substance use?
Well, all of our agencies, juvenile justice, child welfare, they're very much understaffed. And even when we legislatively pass things saying it has to be this level of a mental health professional to do screening and work, we don't have enough of a workforce. So we're definitely cutting corners doing that.
This would be Nevada.
For Nevada. So we that's why we need to, there's so many benefits to building our mental health workforce here in Nevada, and our most vulnerable kids often get the shortest end of the stick.
Annie, there is increasingly a trend to develop a continuum of care for people who have substance use disorder that would get over the fragmentation of the medical system, where a doctor might be in contact with someone who discloses that they are using substance use disorder or might just identify it on her own. That has to do with issues such as housing, stabilization of economic opportunities. Do we have something similar? Do we have practices for once people die? What does it look like at the end?
Well, it depends. So when somebody dies through a suspected drug overdose, there are some programs in place. The coroner's office usually is, the police will respond, and then the body is transferred to the coroner's office. They have incredible human beings who work in there who help support the families and connect them to the different services that we have locally. And so from there, that's often how the services are distributed or connected to.
And we have heard a lot about lack of physicians specializing in substance use, lack of people in mental health. We almost never think about the coroners, about the pathologists doing the autopsies. What does it look like in that space, whether in Nevada or at the national level?
Oh, we need so many more nationally, locally. This graduating class of ours, we have our first pathologist, so that's very exciting for us. But yes, we need them so desperately in our country and in our state. Across the board, the numbers are very low.
What is the time between the deceased person is brought in and the time that it takes to do the autopsy?
Again, that will depend on the jurisdiction and what's happening in that particular office. So it could be a variety of factors that would change that, but it
could potentially be weeks, correct?
I don't know how long the body would. I don't believe it could be. They could hold the body for that long if there were different things going on.
Well, I have many more questions. I will come to some of them perhaps, but let me give all of you a chance to ask questions. Please raise your hand.
Hi, my name is Jonathan, a social work student here at UNLV, and I really like studying harm reduction practices. And I wanted to know, what are you guys' opinions on implementing a supervised injection site here in our community?
California's been trying to do that for quite a while, and it keeps getting stopped. New York has successfully done it. Is it Rhode Island or somewhere's passed? One of the eastern states passed a "We Want Harm Reduction" bill, but they actually haven't opened a site. We haven't had a lot of conversation around that, but if we look internationally, like at Canada, it makes a huge difference. And that's part of the deaths, I think, about men. Like if you look at Vancouver, for example, the people who die from overdoses are often construction workers and professionals who are doing drugs at home alone. So when they do overdose, no one finds them. Whereas if you're doing drugs in the street and someone notices you, then you can get the Narcan. So sometimes our fatality rates are actually in the unexpected populations because of that lack of supervision. So we just haven't a lot of conversation in Nevada about it.
There was a bill in the last session that, in our state legislative session, that attempted to do that, and obviously it didn't pass because we don't have those. So I don't think it was brought back this session.
What do you think most of the pushback is? Do you think it's mainly the stigma surrounding having that kind of facility here in our community?
I don't think we have enough conversation around harm reduction. It goes back to that stigma, and it's like somehow you're tolerating drug use by providing anything. I mean, we do have our vending machines for clean needles, and we've led the way in Nevada on a few of those initiatives. And the science always shows that keeping people healthy, people even in addiction deserve to live. So we have to raise that conversation, but it takes us to bring that up because most people aren't thinking about it.
Mm-hmm. Yeah, I would just also add, nationally in the United States, and even in British Columbia or Vancouver, one of the important data points is that people tend not to die, and that they avoid lethal drug overdose in the overdose centers. At the U.S., there is still legal challenges, even in places like New York, where Mayor de Blasio initiated a process that took several years to come. Even as late as 2023, there were federal legal changes to get the facilities shut down. But there were also pushback from local communities, and we saw that in California, in San Francisco, in the sites in New York from local communities, often under-resourced communities, as well as even Vancouver, as petty criminality, drug paraphernalia, litter would be associated around the sites, and the communities often protested, felt unsafe, were not happy with the sites, even if the sites were actually saving people's lives in them. So I think one of the important lessons is to think how to reduce the harms associated with the harm reduction, how to change perceptions of the community, whether it's better cleaning around the facility, whether it's educating the community, whether it's having policing that does not prevent users from accessing the site, but at the same time addresses concerns about robberies or petty criminality, as users do not have the ability necessarily to hold jobs and thus resort to predatory property crimes to access money overall, including for the drugs.
But to be fair, when you didn't have the harm reduction sites, there were still needles and communities where people will congregate and live. And so the harm reduction sites there's always going to be those issues of, the economic disadvantage.
Yeah, absolutely.
Aaron, School of Medicine. With an issue this big and this deep, can you talk a little bit about the effective public-private partnerships that are operating in our community and what they're doing?
Well, I can start with, speaking of the medical school, ways in which we can at least educate and spread the word. So out of our department, we run what's called a Child Psychiatry Access Program, whereby we have a cohort of child psychiatrists who educate primary care clinicians statewide about a host of topics, and one of which is around how to properly screen. We know that screening, brief intervention, referral to treatment, the SBIRT model, and there's a couple of different variants, are national models that can be done in the primary care setting to just get used to having the conversation, to ask a couple of brief screening questions to identify somebody who may or may not be at risk and get them to the next level. And so I think that as we use our educational reach as a school to train clinicians that are outside of the mental health space and basic, general pediatrics, internal medicine, family medicine, about how to ask the questions, that's one step towards fostering a partnership of having an informed community that can help our population.
Yeah, I think another one for me, we've been working with the Center for Mind-Body Medicine since the 1 October shooting. And in the last recent years, the Agassi Foundation has begun funding our work to bring this work into the K through 12 space. Excuse me. So what's really wonderful about that is it's teaching young people skills to self-regulate, to notice how their emotions are, and to cope so that perhaps, hopefully, then they're not reaching for something else.
Jamie, if it's you behind the mask, I'm wondering if you want to come in as part of this conversation, given the tremendous work you're doing.
Actually, can I pass the mic to Kat Fulber? She is our expert on harm reduction from Southern Nevada Health District. Right here.
Okay. Hi. What's the question?
Public-private partnerships broadly, whether in harm reduction or broadly in dealing with substance use.
Yeah, so when it comes to public-private partnerships, you really can't do this work alone. Truly, this work has to happen within community and for community and by community. And so therefore, it is essential to both build upon the public partnerships with groups such as the Southern Nevada Opiate Advisory Council, which has over 300 people who come to our meetings quarterly. We also work going out there, one of the Southern Nevada Health District's key components to the overdose response is through our harm reduction program. So we have our fentanyl test strip program and our xylazine test strip program, as well as our naloxone distribution program to both private companies, whether it is the Southern Nevada Dental Society or to PAC Coalition. Shout out to Jamie. But it is so critical that there's still so much work to be done. A lot of work has happened where we've had these private-public partnerships with people who are showing up to these meetings, who are doing the work, who are issuing test strips, issuing a naloxone, trying to create a no wrong door approach, because we all know that one-stop shop really just doesn't work. Because there's always going to be an agency at that one-stop shop that someone doesn't feel safe with, to make it not accessible, to make it so that there's not, or it's just in a place that isn't accessible, and it's not feasible for everybody. It's a beautiful idea. But creating this, working together with community in places like SNOAC and places like these roundtables and places where you're going and doing that boots on the ground work to create a no wrong door. So we all know that if you need something, we can get you to where you want to go, is so critical to be able to continue to have these discussions and make success happen and keep people alive. I think it was, I can't remember, I'm so sorry, I can't remember your name for the mind-body partnership next to you, Dr. Hunt. Annie, thank you. But as Annie kind of talked about, community is one of those places you really have to be, and we always say the opposite of addiction is community. And with that building of community is how we're really going to reach people, get to where they need to go in their homes, get to where they not only are people who are most vulnerable, which is our unhoused, but so much more than that, and to build into what we need to create as a community.
And certainly one of the concepts of both harm reduction and the continuum of care has been very much meeting people who use drugs where they are, not where we assume they should be, but where they actually exist in their daily existence, what they can access. Jamie, I'm not completely going to let you off the hook, though, because a lot of these private-public partnerships, the work that nonprofits can do, has in the United States been fundamentally dependent on federal money. And there is a lot of changes to budgets happening at NIH, happening in the Department of Health and Human Services. SAMHSA, the body that deals with substance use disorder, has been a critical funder. Massive amount of questions and potentially massive cuts. Can you just give us a perspective here in Nevada? How much roughly, not down to exact dollars, is the Nevada provision of support dependent on federal money?
About 45% of the budget for the entire state, from soup to nuts, from education to healthcare to roads to everything, about 45% of the money that exists in the state of Nevada originates at the federal level. And I think one of the things that we hear a lot with the potential cuts that are coming is, well, we can take money, this can be paid for by something else. If any one of you know of a pile of money that is sitting around currently unused, I would love to chat with you because I have some ideas. And I think that's one of the struggles that we have is if there are federal cuts, all of the money that is coming into Nevada, whether it be public-private partnerships, whether it be, it's not as if our foundations aren't giving money away, but all of that money is already being spent. So if these federal cuts come, we can absolutely take other money to do that, but that money is coming from somewhere. There is not extra money falling from the sky, unfortunately. And I think that's one of the things, we are one of the highest states for reliance on federal dollars, just because of the way our state has been set up.
Thanks. Other questions, comments?
I have a question. We spoke briefly, you all spoke briefly on the panel surrounding the One Pill Can Kill campaigns and sort of prevention in Nevada. However, there seems to be a lot of true prevention programs that address this problem fully upstream, or look at it from more of a fear-based prevention aspect, which is known to be incredibly ineffective, except in very temporary cases, sort of like a quick immunization, not a long-term immunization, for substance use. Can you talk about possibly some of the research that's been coming out surrounding positive norm campaigns or positive social norming campaigns, or some of the more upstream prevention that needs to be happening in this work?
Lisa, would you like to start?
Yeah, and I'm looking to Annie, because when you mentioned the Center for Mind-Body Medicine at the K through 12 level, I think, when we think about prevention at the earliest level, it's as simple as some of the curricula that are taught around social emotional learning, about how to manage stress within yourself, how to manage conflict within peers. And if you're building resilient children, they're going to be less apt to use. And if you are building children and creating societies with a sense of community, that sense of belongingness, pro-social belongingness, all of that is what builds those protective factors. And you don't even have to mention the word drug or a harm reduction. You're really just building a healthy, resilient human, and that's going to be protective against a whole host of things. We know that over the last several years, there's been more and more attention to the ills of social media and the impacts on anxiety and depression, which are at nearly pandemic levels amongst our youth. And so there's a silver lining in that through TikTok and some of our social media campaigns, there's been a lot of content that's pushed out about how to manage stress, how to manage anxiety, and manage depression. But bringing together individuals is also a great way to do it. And I would pass it to you to talk about specific curricula that you're working with.
Right. So I primarily work with the curriculum in the schools that's from the Center for Mind-Body Medicine. But in the medical school, I teach a whole well-being curriculum to help our students manage their stress, their anxiety, and really do so in groups so that we normalize the fact that being human involves struggle. We have pain, we have fears, we have different things that go on. So that tends to help a lot to normalize and bring it into the conversation.
And Annie, I'm also, rather Alexis, I'm also looking at you because we were talking before we started the public event about stress anxiety management needs among adults and the risk that professionals dealing with very difficult topics that can burn out themselves. Would you like to add something to how do we manage our own stress levels?
Well, for all of us that are in helping professions, as we're worrying about our budgets, as we're seeing our colleagues worried, as we're watching people people on the left and the right get upset about the media, that is taking a huge emotional toll on us, which reduces our compassion and our ability to bounce back. So we have to be mindful that we don't have the same, when we worry about our programs being cut, we're worrying about the clients we're helping, but it's affecting us as well. So we have to really make sure that we're taking care of ourselves so that we can take care of others. And it's universal, the stress. It's not a left or right issue. Both sides are super stressed right now. And we have to build that community to help us get through that. It's really critical. So self-care is healthcare. And that's what I would love everybody to know, that we really have to be kind to ourselves as we navigate this stress, because we can't afford to lose our limited mental health field. It's just too important. And the best way to keep going in this difficult work is to lean on each other, to come to events, to connect, to go for lunch with people with other agencies. Connection is always the solution.
Well, you mentioned that as adults we medicate with a glass of wine, chocolate.
Ice
cream.
cream.
Ice cream. I on New Year's Eve, when the Surgeon General said that no amount of alcohol was safe, and all kinds of alcohol, not even the kind of one glass, was safe and could increase various types of cancer. I quit drinking, and I forced my husband within 2 hours of that New York Times article to quit drinking all alcohol. And and neither of us were drinking too much, but we enjoyed a glass of red wine. And all of our friends said, "How could you possibly do it at the time like this?" But I have not been able to cut myself off from chocolate.
Yep.
Other questions? Please.
Hello, thank you so much. Natalie Brown with Nevada System of Higher Ed. And we've talked a lot about community. We've heard, just about everybody talk about the importance of community. And in this era of more social isolation, disconnectedness across all age ranges, what are some, and I don't see that dissipating anytime soon, what are some strategies to combat that and build that community?
Annie and I during COVID would meet outdoors and walk. Like, find someone who's like an ally or a champion. It doesn't have to be like we're different departments and everything, but find someone who's like-minded and take a break from work or do something that is good for you. And it's relatively simple to do, but we, especially at the university and a lot of agencies, we're very siloed. We're not necessarily in competition with each other, but we are for funding, for attention, for resources, for recognition. And we have to sort of break through that as individuals and go for lunch with the people who are different from us, or we have a lot more in common than we do. So we have to make that choice.
Sarah, would you like to add anything?
I wish I would have been invited for those walks. Just kidding. I think it's just always going to be an ongoing need to focus on that sense of community and connection, especially as we continue to just be more of this digital world. I'm even thinking about stories I hear now about people bonding more with their AI chat than humans. So I think it has to, I'm hoping we can still just go back to pulling people together face to face in different ways in different groups to build those connections, but also thinking outside of the box in those different ways. I think within the work that we're doing for the behavioral health workforce development space, trying to find, especially in the K through 12 space, the high schoolers, those that are interested in behavioral health. We see more and more these peer support groups that are popping up in high schools, where high schoolers that are interested in getting some training to be able to be a peer support for their classmates. That's a growing model, which I'm encouraged by, and also think, boy, those are students that maybe if we could come in and talk to them about, if you really enjoy this work and it's meaningful for you, did you know you could turn that into a job? That's something that's encouraging in that workforce development space. But we've also talked about, to your point about silos, how we could even, I'm looking at Roberta in the back there, how we could even bring together like our training programs within UNLV are familiar with each other, but do they know the psychology faculty down at Nevada State University? Do they know those that are teaching over in College of Southern Nevada? And so we're looking at ways to even maybe bring together like the faculty, the educators, to build that sense of community, but those connections between the programs. Yeah.
And Sarah, that's why I turn to you. I mean, there are many ways to build communities, and obviously shared experience or discovery of shared experience is a component at the individual level. Where just dedicating time to be spending with friends and meeting ideally new people who can become friends can be an enormous challenge as we lead enormously busy lives where between just the nuclear family and the professional job, so that could go 18 hours of a day, and especially at the time of tremendous policy turmoil and tremendous policy change, every minute can be simply sapped on responding and coping with what's happening. But there also is, I think, real advantage to be very purposeful in the workplace, to be building communities, whether this relates to substance use or it relates to many other aspects, and encouraging a sense of community, the ability to share concerns, the ability to share challenges and response in them can be very purposeful endeavor. And in the United States, we have historically done far worse at it than in other countries, such as in Europe.
Caring about this issue is difficult. The stories we see is really difficult. So you should all give yourselves a pat on the back for coming and educating yourself and being here, because we're all busy. It's hard to carve out an hour to sit and to think about a difficult topic. So remember to celebrate yourself for working in the area that you do.
So I'm looking at you. Do you want to ask a question that we were mulling before the event?
Hi. One policy I read about was the notifying of physicians when a past patient of theirs has passed from an opioid overdose. What do you believe the strengths of positions like that are, and largely centering physicians in attempting to deal with overdose deaths?
Well, I'll speak up as a physician on the panel. I think that sometimes in discussions around substance use and overdose, physicians are left out of the discussion. Especially let's say that you are a subspecialist nephrologist and all you do is deal with kidneys, and you wouldn't even think about this. It wouldn't come across your table. And so being able to engage physicians in a more meaningful dialogue just increases the population of individuals that might have the potential for that second of impact. So when I think about child mental health, we know that most kids, first of all, don't get any treatment for any sort of mental health issue. And for those that do, it happens in a primary care setting, pediatrician, emergency room, family medicine. Why aren't we equipping that whole cohort of individuals to have the ability to have knowledge and a dialogue, to know what questions to ask? Because all it can take is that one person that maybe shows a smidge of interest that says, oh my goodness, I hear that you're stressed about blah, blah, blah. Let's try to get you connected to this individual or this group for some sort of a resource. So although I might not be directly answering your question, I think it's about awareness and bringing it to top of mind, so that although a physician might get completely pulled away into whatever the crisis of the day is, this is a way to keep substance use and substance misuse and risks at the top of their brain.
So I will ask one last question from the audience. Then I have one final question as well. So going once, going twice, please.
I was wondering if overdose is more common orally or through injection, or are there statistics on that?
I don't know the answer. Actually, when a pathologist, or Lisa, when a pathologist is doing autopsy, do they have the ability to say whether it was injection? I mean, I suppose there could be marks on, if it's a heavy injection user, there would be visible marks, but not necessarily, right?
Not necessarily, but likely.
But you'd go based on a toxicology or a drug level, and so how did it get there? I can share anecdotally of the patients that I come across that are showing up positive for fentanyl in the ER. They're almost exclusively using it orally and or intranasally.
Okay, I will violate that. I have to ask Bill.
Well, I apologize if this is not too specific a question, but you talked about a lot of policy issues and some solutions. If I could give you the magic wand that none of us have in public policy, but is there one thing Nevada could do in the short term to address any of these issues that we just aren't facing up to yet?
So that's a brilliant question because it actually does not violate mine, because my last one was going to be the Nevada legislation is currently in a session. What is the core policy issue that you would like the legislation to, the legislatures through legislation to address?
I'll jump in with what's actually being heard right now in our current session. So going into today, there were 3 bills I highlighted related to opioids. So the governor put forward Senate Bill 457. People are calling it his crime bill. And part of that would lower the amount of possession of opioids to be a Category A felony. So it would lower it to, if you had 28 grams of fentanyl, then it would now be classified as a Category A felony. If someone is caught with 4 to 14 grams, then now it would be classified as a Category B felony. There's also Senate Bill 337 from Senator Lang that asked the Department of, or I should say the Division of Public and Behavioral Health to work on creating a non-opioid directive for patients to start using. So if you, in part of your healthcare, would like to be considered as a person who you prefer not to have opioids prescribed for whatever reason or whatever health issue you're being faced with, then you would have access to that kind of document to have on file. More related to Nevada System of Higher Education and our NCHE institutions, Assembly Bill 394 from Assemblymember Brown May asked the Board of Regents they may require our higher education institutions to adopt an emergency response plan to opioid-related drug overdoses on campuses. So as of going into those today, those 3 bills were still active. Today is a big deadline, so they have to be passed out of their first house to make it into the next one. So that's just some current policy happening in our state.
And maybe I'll just give an opportunity to you, Lisa, Annie, Alexis, regardless of what's happening on the bill right now, what would you like to see to be on the books in the Nevada legislation? Maybe starting with you.
Well, I will share a fantasy, which I recognize may have zero grounding in reality. But if it were feasible to have a thread of SEL, social emotional learning, that starts in pre-K within the public education system that can go all the way up and through into the high schools, I think you would be able to see measurable differences, not just in substance use, but in delinquency. And we've seen models have existed in other school districts where social emotional learning curriculum has led to decreased delinquency and other problem behaviors in school districts. And so if that could be created, funded, and carried through, I think that would be amazing for us.
Okay, social
emotional
learning.
Yes.
Annie, your fantasy ideal magic wand.
I second that fantasy. I see like that thread throughout from the cradle to the grave where there's this holistic support. And for anyone who's currently using, that there is connection to care, and that we also shift out of these old ways of thinking about addiction and into a more pro-social, pro-recovery movement.
Sarah, I'm giving you your chance at the fantasy.
Yes, fantasy. A couple things come to mind. I always think in our state, we do a lot of work on expanding the physician pipeline, graduate medical education, GME. You hear that every session, and there's a lot of resources that go to that. I would just ask that it's always equivalent to graduate mental health education as well. So whatever we're doing for physician pipeline, which is important, totally, that we do the same for graduate mental health education. And then a second thing I would be kind of going back to what we were talking about earlier, access to care would be improved if we really did more to improve integrated healthcare. So really making sure we have policies across the board that would support primary care practices, being able to hire behavioral health professionals to work in the same clinics, so those physicians could maybe do some screening and then do a warm handoff to the behavioral health professional that works in their clinic.
Terrific. Alexis, your last words.
Yeah, I love this too. More trauma-informed screening and a lot less judgment at diverting kids out of JJ if they are sort of acting out. But any of those solutions, they prevent all our issues: trafficking, bullying, interpersonal violence, drug use, suicide. Like, these issues are all intertwined. We just have to find a way to connect better with our kids and each other.
Well, and I will not state my own, but just direct you to, once again, to the policy papers that we have developed at Brookings that are on the landing page of the fentanyl epidemic in North America and the global reach of opioids that have all kinds of recommendations. Some might be more fantasy magic ones, other very concrete and more realistic in different aspects of dealing with substance use disorder. And my final one is a thanks to UNLV, to Brookings Mountain West for organizing this forum and for the terrific partnership that we have been able to enjoy over many years.
If you'll join me in thanking all of our participants today.
Good job.
So much to think about, and I'm sure you still have some lingering questions. And if you do, please feel free. Our panelists will be here for a few minutes after the event. You can certainly ask those on your own time. Before you leave, if you just give me 30 seconds, I want to share with you the details of our final event for Brookings Mountain West happening this spring. It's actually taking place next week on Wednesday, April 30th at 3:30 p.m. We're going to be hosting our second annual Robert E. Lang Memorial Fellowship Lecture. For those of you that have been following our work at Brookings Mountain West for some time, you probably remember our founding executive director, Rob Lang. When he passed in 2021, we established a doctoral fellowship in his honor, meant to sort of champion his cause, which was improving Southern Nevada through metropolitan policymaking. In order to do that, we provide financial support to a single doctoral student at UNLV each year who is writing a dissertation that focuses on metropolitan policymaking here in our community. This year, we have the privilege of having our Lang Fellow, Amelia Terry, who is a doctoral student in public health. She'll be giving her fellowship lecture on policy decisions and laws that are directly impacting the LGBTQIA+ community and the ways that those laws and policies contribute to mental and physical health stressors for that community. Might be relevant to this group as well, and so I wanted to let you know that that's happening again next week, Wednesday, April 30th at 3:30 p.m. We'll have a nice reception beforehand as well, and the event's about an hour. All of the details are on our website. There's an RSVP link, and I also have lots of materials out on the table as you walk out, including a direct RSVP link for that event, but also our partners at Southern Nevada Health District have left some important materials for you to check out, as well as all of our other materials related to Brookings Mountain West and our upcoming events for the rest of the semester. So with that, I want to thank you all so much for your time and attention and for being here today, and we hope to see you next week. Thank you all for coming.